We're going to open up questions to the audience. We have 15 minutes left. Go ahead. Just introduce yourself quickly, and we'll start you, and then 2 seats down. And just so you can be heard, I'm going to play to be Phil and Alex Oprah.
Tony Cantori from the Retired Public Employees Association. I want to address this question to Judith Arnold. Because you talked about a continuum as people go from publicly funded to publicly subsidized to sole payer. Have you thought about the reverse? Because with public employees, especially retirees, are being forced to pick up higher and higher contributions as a result of collective bargaining agreements in which they're not a party, and especially at the local level. There are many public retirees who are finding that they can't afford health insurance, and they're going to be forced into the public system. So, there's a whole issue there that has to be looked at that I think is being ignored. So I'd like to get your reaction, given that continuum that you talked about.
Thank you, Tim.
I can't answer that specifically until we get the exchange developed, but there are requirements for making sure that people will not be permitted, according to the ACA, to purchase in the exchange if they have access to qualified health insurance. And what that is, and that includes affordability. So if people are priced out of their current insurance and they're able to buy in the exchange, we may see some of that. But there'll also be a push to get people to purchase what they already have available to them. And we just have to see all those numbers.
There are local governments that are dropping health insurance too for retirees as a result of budget crises and that kind of thing.
Okay. We have a question here, and then we'll come back to other folks.
Judy Doshate. I used to work for the Department of Health, and in the 27 years I was always that I worked there, I was always fascinated with how public policy bucks up against public policy. I saw it when we developed the managed care systems going back 25 years ago, and I'm kind of curious how people's take as to what is the real difference between what is envisioned in ACOs and what managed care was initially thought to be dealing with. And the other thing is, there's the state START laws, the federal START laws, anti-referral, kickback kinds of arrangements that I actually think work against some of the idea of patient-centered homes, and I'd like people's thoughts as to whether you think that that's a barrier to implementing some of these changes.
Great questions. Who'd like to respond?
I can.
Senator?
Thanks, Judy. First of all, I am dubious about ACOs. We did do it in the budget. Dick was the driving force in that. But I just don't see how any enterprise that is going to give capitated health care can operate without risk. And and once you have risk, you have to have a reserve. So I just don't see the structure of that. And the federal rules, which I have scanned and looked at a bit, seem to reflect that point of view. So I think there needs to be a risk. Luckily, in the budget, that was not the only modality for moving care forward. We have behavioral health care, we have medical homes. We're going to use the federal option for health homes, which luckily for the first 2 years has a 90-10 federal match. So moving forward, it doesn't negate ACOs. There is language for 7 demos in the state, hopefully to do that. Your other point about the START laws, which are the federal anti-kickback laws, the state START laws, then we have antitrust. They're all questions that people are vigorously trying to figure out. Where do we take current statutory barriers, including the corporate practice of medicine, and where do we move them? And once we move them, what are the intended consequences and what are the unintended consequences? The interesting thing for me was Dick Godfrey had always been very firm at keeping the state version of the START laws. I found he just introduced the other day something that would have us recede to the federal START laws only. So he's thinking about it. I'm thinking, but it's tremendous, given the intense, complicated nature. We do Medicaid, $1 billion a week, $52 billion a year. So we have a lot of vested interests, and there may well be unintended consequences. But it can't keep the current system going and thinking that we're okay. That's obviously what the message is with Obamacare. figure out what you're going to do to change this.
Right. I'm sure the panel will have more answers to that, but I want to get the audience in more time left. We'll go here, and then I'll go back to you.
Hi. I'm Beth Valley, and I work in public health. And I guess the three things that I've learned from our state presenters today, one is that this is really requires political structure to make this happen. It's going to be the state legislature and the governor who drive this, or it doesn't go anywhere. The other thing that it's really a three-pronged approach: cost, quality, and access. And if you don't have, this is what I'm hearing, if you don't have all three working at the same time, then it's not going to be as successful. Okay. And so I guess my thought and question to you is, there must have been folks, because this is an incremental process, there must have been folks who were not happy about having this go forward, true? And therefore, that will happen in New York State. The medical service providers, anyone who doesn't want things to change or afraid they'll lose money, will be opposed to this. Because it's an incremental process, you still have to take the first step. How would you advise New York State to try to manage that, to get to step one, to reassure? What did you do in your states to reassure those that were opposed to this, so you could at least get to step one?
Great, thank you. Why don't we start in Vermont, because there's certainly been a lot of controversy about your step one.
So, interestingly, most of the opposition to H202 came in the second phase of the bill in the Senate, and it came from brokers, really, focusing around the exchange design issues. We had really a fairly remarkable level of, I wouldn't exactly say consensus, because that would be a bit too positive, but lack of opposition, perhaps, from most other quarters. Our insurers were open to discussion around moving forward. Our providers were open to discussion, and employers were open to discussion. So I think because the way we structured our bill was we set a goal, we planned out steps to get to that goal. We have something like 20 reports due next year on different things that we're looking at. When people raised questions, we didn't sweep them under the rug. We said, yeah, that's a question. We need your help in figuring that out. We took a very collaborative approach. The governor, in speaking around the state on single payer, has said, look, we're all in this together. We cannot afford the direction that healthcare is going. And yeah, is it scary to change? Sure. But it's scary where we are right now, because we can't afford it tomorrow. And so we really need to work together to move forward.
Great. Back here.
Thank you. I'm Shirley Johnson-Lanz. I'm a health economist at Teach It Faster. My question is really primarily, I think, for Robin to follow up, and I apologize if I was out moving my car and this was covered in makeup. But in what you described, which has a lot of voluntary aspects to it, I was wondering how a small state with a small state budget with relatively low median income can deal with the problem, which appears to me to be one of the possibly unintended consequences, which is a lot of crowd out, where employers and particularly small businesses start dropping their coverage and putting people into the public option. Have you considered that?
Sure. So the way that we are approaching the financing for the single payer is to work on a financing plan over the next couple of years. We are assuming, however, that it will be a publicly financed system. So our goal, and actually we've had 3 different studies over the last 10 to 15 years around healthcare approaches, all of which considered single payer. And all of those studies have come back saying, you don't need to raise extra money. You can pay for what you have with what you're already paying and cover the uninsured through simplifying administration, addressing fraud and abuse more directly, because you have one pot of data. You don't have your data dispersed. You can really see on an individual person-to-person level what's going on, through pushing health information technology and simplifying some of those systems. So So I think that's the approach that we are taking, and through our next few years, we're going to be looking towards how do you actually achieve that. But our assumption will be that everybody is going to be covered by Green Mountain Care by virtue of their residency. And our assumption would be that there will be employers, especially small employers, who cannot currently afford to keep their coverage, who will drop insurance, and people will move to the public coverage. But it will be publicly financed. So everybody will be covered and everybody will contribute.
And what's been the posture of your larger employers towards this? I know there aren't a lot of them, but you have some significant employers.
IBM. Yep, IBM. IBM, as you may know, is a multinational corporation. They operate in countries that have, guess what, single-payer healthcare systems. So while I would not say that they have been an enthusiastic participant in our planning, they are open to discussion. And they didn't come out against the bill. They came out with cautions. They had some concerns about how the financing would be structured. And we have expressed we want to have a dialogue with them and try and figure out a system that works for them and our other large employers as well.
Question here, and then we'll wrap up.
Thanks. Sorry for apologize for my voice. You'll hear me. Jessica Wisniewski from Citizen Action, but also Healthcare for All New York, our large coalition of healthcare advocates. I guess my question is for both Judy and Senator Hannan. As New York looks in these final weeks to do legislation to establish the exchange, I think, and what I'm hearing from other states has kind of reinforced that there's many complex policy issues that we can't come up with the answers for. There's studies happening, running numbers. We don't expect, all of the answers. But I am wondering if in the legislation that you all are working on in each of your offices, will there be some very specific placeholder studies with time frames to come back either next legislative session, hopefully next legislative session, to kind of have the exchange, once established, make some real recommendations, particularly around a public option and things like race equity, merging the market, individual and small group markets, all of those kinds of questions. Will there be those kinds of placeholders in the legislation this session?
Thank you. Senator?
Before I get to your answers, I just want to say two things. One, if you're interested in more information, I'll say this as kudos to the administration, there is, under a website for New York, for healthcare reform in New York, some really good information. The administration has put up, and probably Judy Arnold has put it up, quarterly reports, and you can get a sense of exactly the progress that's moving forward. And it's a lot more detailed. I had a chance to do today, and it will be more detailed, so it's a good way to follow. The second is, as we go through this, let me caution you that while Massachusetts is way far ahead, and Vermont and Connecticut have moved, and there's about 3 other states, not one state has received federal approval yet. So we don't have, actually the rules of the game haven't been written totally yet. And that's kind of the peril, even though the exchanges are supposed to be up by 2014 and by the rules in trial existence by July 1, 2013. Will there be absolute legislation? We're all going to put in drafts. I'm working on mine right now. I know the administration is, and we have to get together and compare notes. The basic thought was out of the roundtable, I got a lot more detail out of the roundtable the Senate had, and it's all on the website on the Senate Health Committee and the Senate Insurance Committee, of having a structure. Probably it's going to be a public authority because it's easier to do, easier to see, easier to be accountable, but holding off policy questions till for some really big and important policy questions. Go ahead, Judy.
I can't speak specifically to the legislation we're working on, but I can tell you that we're looking at making a decision on governance, and we're looking at leaving other decisions for next year's legislative session and maybe even the year after. And I can't say what will be in and won't be in terms of dates and studies, but the Health Department and Insurance Department are developing those lists of these are the decisions that we're not ready to make. These are when we think we'll have data on the studies. And here's when we could make these decisions, so maybe we could put that in statute. But I can't commit, we're not the people who make the decision about what ends up in statute. But we're thinking along those same lines.
Great. We're out of time, and I want to respect that. It just strikes me, having started doing this work in 1986, that we've come a long way. It sometimes may not seem it, given the problems that remain in the system. But one of the fun things, I guess, about being around a long time is you do have a perspective. And the kind of progress we've made in New York, the kind of progress we've made nationally, these are really complicated issues. But it's exciting to hear them being worked out, having been place in one state, being tackled in innovative ways in other states. And the history of New York, even with the 3 weeks left in the legislative session, I suspect that New York will take one more step forward towards moving on the exchange, and next year tackling a lot of these really big questions, which as Brian said at the start, will be a continuing process. What goes on, the biggest change really in some sense, when people ask me what's the Affordable Care Act about, it's now clearly the government's responsibility to make healthcare affordable in the country. That's the big change. There's all sorts of problems with the Affordable Care Act, but for the first time there's an assumption that people in this country should have access to quality care. And once that's a public responsibility, the whole discussion changes, and these kind of settings become the real meat of our healthcare system, not the sideshow. So thank you for all your time. Thank you all for participating.